Okay, welcome everybody. If you don't know me, I'm Abby Stork. I'm Abby. My hobbies include. I thought we'd talk about UTIs today. We see a lot of recurrent UTI patients. So a lot of this is just kind of the basics. What is a UTI? What's a recurrent UTI? How do we diagnose them? What tools do we have? What do we do? What's our workup? Why do we do it? Because we're scheduling all those appointments. We'll talk a little bit about treatment prevention. Most of this I'm trying to kind of keep at the level of somewhat for like the front desk staff, but also definitely for like all of my peeps who are triaging these phone calls. So I'm hoping that a lot of this will be able to have kind of a dialogue back and forth about what our protocol is, what questions you guys are getting, and how to kind of best triage those. So first of all, a UTI is a urinary tract infection. There are different ways of defining this. I wish I could say that there is like one gold standard test that we can do that says you have a UTI and you don't, but that's not it. So mainly, if you like, how do we say someone has a urinary tract infection? We're going off of symptoms, evidence of inflammation in the urine, and then actually growing out bacteria in the urine. So symptoms. Classic symptoms include dysuria. That is the word for burning pain with urination. That can either be at the urethra, or that can be kind of like in the suprapubic area. That's the area right behind your pubic bone where your bladder sits. Dysuria is interesting because people say it burns when I pee, and sometimes what they mean is their vulva hurts, and that could be a vulvar issue, but certainly that's a good one. Urgency, frequency. Suprapubic pain, that is that pain above the bladder that's kind of persisting there. And then hematuria, that's our word for blood in the urine. Suprapubic pain, hematuria, some people will say those ones are typical symptoms, some people say they aren't. Symptoms that are not really characteristic of a UTI. They can be seen at UTIs, but all of the like American Urologic Association, kind of the Urogyn Association, all the papers say, people who call and say, well, my pee smells funny. I have cloudiness in my urine. I'm confused. They can be seen with urinary tract infections, but that is not my favorite way to diagnose them. Now that being said, I am fine, like, we probably overtreat and overcatch UTIs. It is not your job to tell someone you don't have a UTI because your urine's cloudy post-operatively. Like, I think it's still right to test them. But I do tell people, like, if their only symptom of UTI is their urine looks cloudy, they have no other symptoms, I'm like, I don't care about that. Like, you can have cloudy urine, that's not dangerous to you. So knowing the symptoms, and then if we're getting really technical about like, a lot of our job as providers is patients come in and maybe they have bacteria in the urine, maybe they have symptoms, and we're trying to figure out, are these actual UTIs? So one thing we'll sometimes look for is evidence of inflammation. And so that is looking actually inside of the urine, where we send off urinalysis for microscopy. We'll talk about that in a second. And we're looking for white blood cells that are a sign of inflammation. That basically tells me, yeah, your body is detecting a problem and it is mounting a response by making a bunch of white blood cells and spilling into the urine. And then the final thing that we really look for is bacteria in the urine. How do we do this? Urine culture, that is the gold standard. So with the culture, we send off the urine, somebody puts it on a petri dish, they grow it in a lab for 2 to 3 days. We're sending these out so often, they take a little bit longer. They then actually look at, I don't know if it's a person or a computer or what now, but they actually look and they count how many colonies are being formed of a specific pathogen. Typically, any lab is gonna report more than 100,000 colonies as positive culture. In reality, if someone is symptomatic, more than 1,000 is probably sufficient, but we'll get into that a little bit more. And then just briefly, mixed urogenital flora is, I consider that negative. So it's gotta be a real pathogen. So really classically, when I am looking at a recurrent UTI patient, I'm saying, are you having classic symptoms? And are you having cultures that show bacteria in the urine? Inflammation is kind of a secondary thing I look for. If they don't have any white blood cells in the urine at all, it's probably not an infection. But people can have white blood cells and it not be an infection. So no diagnostic test is perfect, but we will talk a little bit more about those. So briefly, this is how we define a UTI. A recurrent UTI is 2 of these episodes in 6 months or 3 in 12 months. Ideally, they are discrete. So you have a UTI, it clears away and then it comes back. If it's like, oh, I had a UTI and then, I got an antibiotic and I never really got better and it was like 3 months, it's kind of like, it could just be one big UTI. Some of it is semantics, but that is kind of gold standard, and that's why we will often try to get cultures on these patients when they're establishing for us to like actually establish this diagnosis.
And the other things that which is a bit trending is that, you know, our patient population is not the average patient population. You know,
Yes.
we have so many patients with recurring UTIs, and we're doing things that create UTIs, and so you know, there are strict definitions, but like I think she's alluded to that too, is that you know, we have a little more flexibility in some of that just because we see it so much.
Yes.
And it's so common. That's okay to bend these a little bit as needed. But
And I think with the symptoms, since we're talking about this here, if you are just going by symptoms,
yeah.
every single person
Yeah,
who
every
comes
person.
through our door is gonna have one of these.
Yeah.
Not every, but most of them, you know, urgency, frequency. So it used to be, if you looked at the literature on OBGYN, they'd say, if you ask a woman, does it burn when you pee? And do you not have vaginal discharge? And they said, yeah, it burns when I pee and I have no vaginal discharge. That was like 90% accurate at diagnosing a UTI. That is a premenopausal woman. That is not who we're, I mean, we're seeing some of those, but that's not who we're seeing. Or we're seeing people who are coming to us because they keep coming back, they can't figure it out. So that, I mean, this is a lot more nuanced. And I think the important thing too is, again, we have a post-op population, we have a sick population, we have women with prolapse and retention, we have women who are coming to us with urgency frequency. Part of the workup for those symptoms is you send a UA and a culture to evaluate for an infection. If it's positive, I often over-treat these in the hope that I was like, okay, well, if it's just a stinking UTI and your incontinence gets better, well then fine, let's cure it. Knowing that we probably treat a lot of asymptomatic bacteria here, and we'll get to that in a second. So when we talk about urinary tract infections, typically what we are talking about is acute simple cystitis. So that is the medical word for just a bladder infection where it's down in the bladder, it's down in the urethra. We have some nice natural mechanisms that keep it from going up to our kidneys and ureters. The things we worry about and the reasons why we treat people early and we take this seriously. One, to improve symptoms because we're not monsters, but two, to prevent it from getting up into the kidneys and causing pyelonephritis, which is a kidney infection. More severely, it's to prevent sepsis. Sepsis is a lot of definitions, but essentially it's like you're systemically ill, your blood pressure is low, you're spiking fevers, your heart rate is high. It can affect things like the kidneys, the liver, the brain, like all platelets, clot, all these other things. So obviously we want to avoid that. But you may see us being a little more aggressive with patients who are coming in and they're like, yeah, I've been hospitalized 3 times for kidney infections and sepsis and all those other things. Usually these things are not happening in young, healthy women unless they have like a urinary tract abnormality, like a stone or some other weird thing. In our older women whose just like immune systems aren't as good, though, the risk of this goes up. And certainly there's a lot of like weird diagnostic clarity that happens where people are like, well, I came in and I was just a little confused and they told me I was septic and I had no symptoms. So that's where, we'll sometimes get these patients who are really like, I need antibiotics right now because they had that really scary experience. And that's where there's like no guideline that's going to tell you what to do. That's where there's a lot more of like the art of medicine and where I think it's very appropriate to rely on your providers to make those decisions. I would not expect that of you, but this is kind of, we're hopefully mostly managing the simple cystitis stuff. In that vein, briefly, and we'll talk more about this I think at the end when we do questions, triaging UTIs. So red flags, things to me that they need to go to the OR. If someone's like, I maybe had one temperature once, they're otherwise feeling fine, we think it's a UTI, whatever, like, that's fine. But if someone is persistently fevering and is like unwell, they need to go to an ER. Nausea, vomiting, can't keep fluids down, can't keep food down, to the ER. They are in severe pain, especially if it is flank pain. By flank pain, this is not flank pain. This is where your ribs end is like right there is where your kidneys are. So this is what I'm looking for. So pain in that area, but some people will have, if it's an early infection, it may be in their ureters on either side, but pain in that area or just generalized feeling unwell, go to the emergency room. For us, our patient population definitely trends towards having retention. A lot of us know that our post-op patients can have retention. You guys are so great about that. If anybody calls in with UTI symptoms post-op, you guys are telling them you must come in for a PDR or go somewhere, and you appropriately counsel them if they decline of the risk. So thank you for doing that. Certainly though, we have some women who have advanced prolapse and they have retention, and that can definitely kind of impact just management and kind of how sick they can get with these UTIs. So it's something to keep in mind. If you have somebody who is like a PDR of 800 at their new patient appointment and they have a UTI, a 3-day course of Bactrim may not cut it for them. The last thing I'll say, if a patient just has some isolated flank pain, is otherwise well, may not be like straight to the ER kind of thing, but that's definitely something that I would forward to the provider. Like all these things are kind of red flags for me that would escalate my degree of concern and not just kind of like, oh, you're, you know, come in when you can and give us a sample. Always, if something doesn't seem right, send them to the ER. I'm pretty conservative, but that the goal is that we catch kidney infections and sepsis early so that they're not on like death's doorstep by the time they get to the emergency room. And truthfully, the ER can just do things that we can't. Namely, they can check labs, they can check vitals to make sure they're not hypotensive tachycardic, and then they can give them IV antibiotics, which sometimes is they just need that to kind of kickstart things. Diagnosis. So how do we diagnose a UTI? What tools do we have? The urinalysis. I call this a urine dipstick. We do this in the office all the time. You may see it on my notes abbreviated as a U-dip. This is different from a formal urinalysis with microscopy that we're sending off. So this little dipstick, there's different things that we measure on it. You stick it in the urine, it reacts with them. There is a little bit of subjective interpretation where you're kind of staring at it. The main things that I'm looking for here are leukocyte esterase, nitrites, and then a little bit blood in the urine. So leukocyte esterase is just a marker of inflammation, certainly very often positive in UTIs. It's a sign that your body is mounting an immune response. There are a lot of reasons it can be a false positive, particularly if it is a clean catch specimen, especially if you're post-op. Anything with vaginal secretions, especially post-op, but even like a physiologic normal vaginal discharge has some white blood cells in it. You bet your bottom dollar there's a lot of white blood cells in post-op discharge. So that is a really common cause of fault. So if somebody comes in, they have like 1+ leukoesterase and everything else is negative and it's a clean catch, that's like pretty equivocal for me. Like that's not that convincing. Nitrites I do think are a little bit more accurate in predicting a UTI, with the caveat that azo, aka phenazopyridine, can cause a false positive. It can cause this to be present. But if somebody comes in with leukoesterates and nitrites and they have not taken azo, my suspicion for a UTI goes way, way up. Now, not everybody is gonna make nitrates. One of the reasons is certain bacteria just don't have this little enzyme that converts nitrates into nitrites. It's kind of a technicality, but Staph Enterococcus pseudomonas, you're not gonna see that. So it is, again, it's not a perfect diagnostic tool. And then if you're catching them really, really early, the bacteria haven't had a chance to like transform all these nitrates into nitrites, and so we won't see that yet. Then finally, blood. Sometimes we'll look for that. Not everybody has blood with an infection. Certainly some people can. There's other reasons people can have blood on a specimen, but that's, people have leukoesterates, nitrites, and blood, and symptoms. I'm like, yeah, it's probably a UTI. The results of the dipstick do not predict the severity of the infection. So if somebody has all 3 positive, they can look fine, and some people will have maybe trace leukoesterase and be sick as a dog. So that it's not a great predictor of illness. But if, like I said, if you do have leukoesterates and nitrates, it's about 89% positive predictive value, meaning that it's about pretty accurate. Urinalysis with microscopy is not available to us as point of care testing. We send this off. I think historically, you really can't see this, but in this, in this image, if you squint, you can, these are like little red blood cells that you can see, but literally what they're doing is they're sending off urine, they're putting it on a sheet, they're looking at it under a microscope. Most of this is automated by computer, but it's more accurate. So a lot of things can cause the blood test on a dipstick to be positive when it's not. So this is actually able to count like the number of white blood cells, the number of red blood cells in the urine. So as an aside, when we're doing a workup for microscopic hematuria, if the dipstick is positive, but there's no red blood cells on microscopy, I don't care about the dipstick. I care about the microscopy because microscopy always trumps dipstick. So these are kind of the snapshots, but kind of long story short, no urinalysis is perfect. And unfortunately, there is we can try to come up with a protocol, but there is definitely a little bit of an interpretation, figuring out how bothered is the symptom, is the patient who's calling in, how badly do they want the antibiotics? And I do think there is an aspect of patient satisfaction, yeah, but like also just like giving people relief. And I think you guys do a pretty good job of like, if they really want antibiotics, they're really bothered and they have an equivocal dipstick, like maybe treating them and sending off the culture at the same time. Urine culture, like I said, gold standard. They send it off, takes several days to come back, which is painful. So a lot of times we get the urine so that we can send off the culture, because if we start them on an antibiotic beforehand, we might kill off enough of the bacteria where we can't tell what they had and if it's resistant and if it was, more importantly, is this a true UTI? So the urine culture does a few things for us. It helps us guide treatments. So when they grow it off, they can grow it and actually grow it with different antibiotics to figure out, are you resistant to all these different classes? So it helps us guide, you know, if you're not getting better after 24 or 48 hours, okay, well, it was resistant, that makes sense. It also helps us clinicians diagnostically to know, are these all UTIs versus is this something like interstitial cystitis? So classically, more than 100,000 is positive, but if you actually look at the literature and in specialty clinics like here, a lot of people say it's reasonable to treat more than 1,000 colony-forming units per high-power field. That's how we measure it, especially if it's a straight cast specimen. Truthfully, most labs won't report less than 1,000, so it's kind of a moot point about whether or not you treat those.
Yeah, I think that piggybacking on what Dr. Stork was saying, you know, because we see these patients coming with IC and all sorts of other stuff that they're new to us, I kind of tend to just, especially if we don't have the positive results, and also treat. I think most people, so it's cool for patient comfort. But as they progress through the clinic and start seeing it more and more, this should flesh out. We should be able to see exactly what is this, is it UTI, is it IC, whatever it is. So
I think that's helpful if like you're able to look and see like, okay, they've called in 5 other times, all of their urine cultures have been negative. That's someone who I really want to send off the culture and see the results before we start an antibiotic willy-nilly. And part of this too is that if a urine culture comes back, we'll talk about negatives in a second, but that's important information for us, but it's also important information for the patient to know, like, this wasn't a UTI, because so many people walk around thinking, we gotta get these UTIs under control, and it's like, no ma'am, that's not what this is. So for the people triaging, a lot of these are gonna look familiar. E. coli is the most common cause of UTI, 75 to 95%. Proteus is a known, I call these uropathogens. This is just a name for bacteria that in the literature we think actually causes UTI. Proteus, Klebsiella, Staph saprophyticus, Pseudomonas is one we're seeing more and more. That one's tough because it's resistant to a lot of things, and they often don't report sensitivities, or if they do, it's like a bunch of IV antibiotics. Yeah. So that one's a little tricky. These are ones that are considered contaminants. Lactobacillus, that is a normal, healthy bacteria that grows in the vagina. Group B strep, so this one's a little controversial. We treat it in pregnant women. The general consensus is Group B strep is a contaminant, and we do not treat it. It's not a cause of UTIs, and I think that there's a lot of wiggle room. Have I treated Group B strep UTIs? Yes. If somebody comes to me and they're like, you know, it's a straight cast specimen, they grew out Group B strep, they're super symptomatic, we treat them, all their symptoms go away, fine. Maybe for you, this was like enough that your bladder reacted and it caused inflammation. Like UTIs, it's not black and white, it's a little bit of a spectrum. In general though, if someone's coming to me and they're like, they keep telling me I have Group B strep UTIs, they don't really have any infections, I'm like, so there's a little bit, so these are ones where I don't think it's unreasonable at all to send to a provider if you have questions about, but I would not like empirically start people on treatment for these. Cyanobacteria is likely a contaminant. Coag negative staph is usually thought of as a contaminant. Again, have I treated some of these? Yes. And then there is newer testing going out for things like mycoplasma, ureaplasma. That one is really controversial. There are some people who say that they cause UTIs, there are some people who say they don't. The testing is usually sent out in advance. That is not part of my practice, partially because it's expensive and partially because I'm like, I don't know what to do with this. If it is positive, I'm not convinced that it's like a true cause of UTIs. So I don't know if you guys come across that, but that is not something that is standardly a part of my practice unless someone is coming to me and that, you know, they've been told that and they're specifically asking for that testing and treatment.
I do it after a week and also rolled out and still have symptoms.
Mm-hmm. And then do you see they get better with that? Yeah.
But it's really actually, it's kind of a last result.
Yeah.
Short after everything.
Yeah.
They've been doing some STI testing and constant STIs.
Yeah. Cause I've seen that too, yeah. So I think that's kind of like a gray area, but it's, you know, I think usually the people who've done it is like, well,
It's not standard.
we're like 2 years down the line and everything else is negative, so, you know, you do what you can.
Disease doesn't support you doing your ureaplasma.
Yeah.
I've done it, but they.
Yeah, and I think some of this too, you go to we'll send people to infectious disease docs, they tell them don't take antibiotics, like, they're big, they're antibiotic stewards, so we're trying to avoid over-treating and developing antibiotic resistance. Urine culture, so this is something that I have a little bit of, I don't know what I want to know this, what our protocol is, so when I read about, I honestly don't know how we handle our urine. In theory, the longer, what?
With gloves.
The longer urine sits at room temperature, the more bacteria is going to grow at it because it's warm, it's not cold. So you get a little bit of a contaminant in there, it can grow and become a big contaminant, and you can have a lot of different things growing, and then it comes back as like multiple things and they don't know how to interpret it. Or somebody who maybe had a tiny bit of E. coli all of a sudden becomes a lot of E. coli. Yes.
Is that just if it's sitting in the cup and if it's like in the tube with the stuff?
So that's my question is I don't know, does the tube we get, does it have like a urine transport media? Is it specifically
It's got
for that?
Stuff in it,
Yeah, so I don't know this. I don't, you guys may, and we can have an
Per
offline
lab
conversation
report,
about
they
this.
said room temperature is fine.
Okay, so I mean, and that's where I defer to the lab testing. Presumably they're putting it in something that, you know, we put them in those tubes that they can be sent off. When they collect them at the end of the day, are we setting them outside?
No, he usually gets here at 3.
Okay, perfect, cool. Because that's something I've been meaning to ask as well, because I'm like, you know, like sitting at
A hot summer day, yeah.
really hot summer day, probably not great. It's if you put it in a cold thing, it slows down all of that process. But I guess like, yeah, not great to have a urine cup sitting out for 2 hours and then putting it in there. And more importantly, this is part of the reason why we don't do people bringing in their own. First of all, that's just kind of a mess. But second of all, you know, they would have to be really good about keeping it cold, bringing it on ice, because the longer it sits out, the more likely it is to be contaminated. In theory, if someone is peeing and giving us a specimen, it should be a mid-spring specimen where they pee, like that first amount is discarded, they spread the labia so that there's minimizing contamination from that, and then they actually like collect that specimen. It's hard for a lot of our patients to do. Studies have shown urethral cleansing with like wipes and things like that don't actually make a difference in the actual accuracy of the urine cultures. So for most of our patients, we're getting straight cast specimens. But I know we don't have any signs up in our bathrooms when we're doing clean catch. You know, that is best practice to say like it should be a midstream specimen that, you know, if you can spread your labia with it. So, you know, something to kind of keep in mind with our patients. And then straight catheterization, we cleanse it, we put it directly in the bladder. That doesn't mean there can't be any contamination on that. It's not impossible, but it definitely minimizes the contamination. And it also, you know, reduces, you're getting a pure source of urine. So theoretically, if somebody had a negative culture, for whatever reason, a straight cath should be a little more accurate if we missed something that was just a low level or wasn't early enough. So that is the gold standard. Why we culture, we already discussed this a little bit. There's a lot of mimics that we see in this clinic. Interstitial cystitis is huge. Everybody who comes to me with recurrent UTIs, unless, you know, I look, but unless I have, you know, I correlate culture symptoms, and if it's positive and it's all uropathogens and all convincing symptoms, I'm like, okay, you have recurrent UTIs. Until I have that, you could have interstitial cystitis until proven otherwise. I don't slap this diagnosis on people willy-nilly, but it is always in the back of my mind if all their cultures come back negative. That just means we need to pivot and focus more on, you know, bladder irritants, anti-inflammation kind of things like bladder installations, but it's not an antibiotic problem. Overactive bladder, urgency, frequency. You know, I feel like I pee every 20 minutes and I never empty, big mimic. Atrophy, dryness, itching, burning of the vulva. The number of women who come to me, they're like, I have burning and it's right where the pee comes out, and it happens every time I have sex, and sex is really dry and irritating and painful. We put them on some vaginal estrogen cream, their symptoms get better and they never had a UTI. Stones, so urinary stones, the kidney, the bladder, they can be irritating, they can be painful as we pass them, they can cause blood in the urine, so those can be mimics. Vaginitis, so that's like your BV, your yeast infections, they cause vaginal itching, discharge, pain, and some of that burning with urination. And then other just like pelvic pain disorders, vulvodynia, which is like your vulva hurts all the time, pelvic floor myofascial pain, we call that high tone pelvic floor, all these different things where your pelvic floor spasms, gets out of whack. causes urgency, frequency, pelvic pain, even suprapubic pain. So all these things can be mimics. Carcinoma in situ of the bladder, that's bladder cancer. Super rare in women, but that's part of why we do this big workup is one, to make sure there's no reversible causes, but two, make sure we're not missing a cancer, God forbid. So workup for recurrent UTIs. First of all, we do a lot of workup for recurrent UTIs. If you actually look at the guidelines, universal workup is not necessary. The reasons you need to do it are if they're not responding well to treatment, which is a lot of our patients, but you put them on the right antibiotics, or like quick recurrence, they come right back over and over, or say we put them on suppression and they, are still getting UTIs through the suppression. And then other things like history. So if somebody's had a bladder sling before, if somebody's had a history of stone disease, family risk factors for bladder cancer, I'm gonna do a workup sooner. So our workup looks like two things. One we do here in the office all the time, that's called cystoscopy. It's where we take a camera, we put it through the urethra, and we look around in the urethra and the bladder. We ain't looking at the kidneys, we ain't looking at the ureters. Now if they have an extra ureter, sometimes we pick that up, but that's uncommon. What we're looking for is really structural abnormalities and cancer. So cancer, rarely you're gonna pick that up. There's things called diverticulums, which are outpouchings of the bladder. It's rare that I see those causing UTIs. I have yet to hear a urologist who's gonna take out a diverticulum for that, but in theory, mesh erosion is a big one I look for. So recurrent UTIs with a prior sling, I'm looking inside there to make sure none of the mesh that somebody put in is eroding into the wall of the bladder. That's super rare. Stone disease, we look for bladder stones, any sort of a stricture narrowing of the urethra that causes them not to empty their bladder. Fistulas, those are connections between the bladder and like the colon or the small bowel. It's very rare, but can happen. And then cancer, like I said. And then CT urogram is usually what we're ordering. So that's a CT scan. You can kind of see a cut through image here, but what this CT scan is, it's a very special CT scan. It's not just your run-of-the-mill CT with contrast. They are literally sending contrast through your bloodstream, and then makes its way to the kidneys, which form urine. Those go down the ureters into the bladder. But they take pictures at different times. So in the phase when there's, contrast in the kidneys, they wait a little more, and then it spills into the ureters and then into the bladder. And what we're looking for is masses, cancer. We're looking for stones. We're looking for strictures or something. Most people don't have those unless they've had prior surgeries. But certainly if someone says, I've had a bunch of kidney infections or sepsis, I've had prior stones, I'm seeing blood in my urine, or especially blood between infections, that would kind of prompt us to do this evaluation.
Yeah, I just had a patient, I think it was last week or 2 weeks ago, who she had sent for me for cystos, hematuria, yeah. And she said she had CT urogram, and it didn't pick anything up, and I did the cysto, and then it looked like a cancer at the ureter. And I went back and looked at her imaging. It was actually a CT abdomen pelvis.
Mm-hmm.
And so those just don't give you the definition that you need to look for things like masses and stones. It's very different. So if you're doing a workup for it, we definitely have to make sure the right imaging for like gross hematuria or something like this to identify this stuff.
Treatment. So these are first line treatments per like the infectious disease guidelines. Macrobid, Bactrim, we use all the time. Macrobid's 5 days, Bactrim is 3 days. Sometimes we will do longer courses of those. So people who just got Bactrim a week ago and then their symptoms recurred, and then sometimes we'll do a longer course, especially if someone is intermittently catheterizing, has some degree of retention, we may need a longer course to treat those. The other first line treatment, so fosfomycin, that's one packet. My understanding is that is a little harder for patients to get and can be more expensive. I don't know, have you guys received pushback with that at all? Is that hard? Because I know it's not part of our protocol. What?
GoodRx usually has pretty good coupons.
Okay. This is like gold standard. In Europe, they use it all the time. It's a one-time dose, and it has pretty good resistance profiles. A lot of times for my Pseudomonas patients, where I have no other oral options, I'll use this, although that can still be resistant. And then there's a new one called pivmesilinam, called Pivia. They came and they talked to us a while ago. That's not available immediately. That's like, I think you have to order it through specialty pharmacies like Alto, and it can be expensive. There's no standardized dosing, so it is not first line care. I don't know, there may be like a random patient out there where I have no other options that I would consider this in the future, but it's not kind of up and at quite yet. For a recurrent UTI patient who's coming in, they haven't had UTI in a while, I would treat them with the same standard dose. Certainly, I think it's reasonable to do sometimes longer dosing. Usually I'm deferring to a provider on that one to ask them if they need to do a longer dose. Or if somebody's self-capping, I may say do it for 7 days or 5 days or whatever. Now I will sometimes do a 10-day course, and in reviewing, prepping for this, there's not good evidence that treating someone for more than 7 days ever improves the cure. That doesn't mean we don't do it, but in general, 7 days is probably more than enough. And nowadays, most of these regimens are 3 to 5 days, if not a single
But Dr.
dose.
Stork, 7 days would work for me.
It doesn't work for me. It doesn't work for me. Yeah. And so that's, again, some people, I don't know, well,
So
you
you're gonna
have
that
to go
fight-
off the
you're gonna have that
information you
fight.
have.
Yeah.
We do the best we
I
can.
also think what's missing,
Yeah.
the stuff that's missing there, the Cipros and the Keflex, that's important.
Yeah,
Not
so there
first
are other
line.
things we use all the time. So sensitivities, if people have allergies or have resistance and we don't know what else to do, we're like, well, you're resistant only when you have allergies. Sometimes we'll do other ones. So Cipro is a black box warning for tendon rupture, so we try to avoid it now. But if somebody has a kidney infection, it's actually first line treatment. Cipro and levofloxacin, they both have that risk. And I kind of put this on here, especially for us providers, just to be aware. Like if somebody comes in and they maybe are developing early kidney infection, I'm gonna choose Macrobid because it doesn't penetrate the kidneys. But if you choose something like Bactrim, sometimes I'll pick that one because it covers my bases a little bit better if I'm a little worried, like they sound a little sick, but not like sick enough they need to go to the ER. Same with Augmentin, Cefuroxime, there's some other ones. I just threw a few up here. So I don't expect anybody here to be managing pyelonephritis. I would like to be involved in that. But this is just kind of like an FYI and something to be aware of, that some of these, the reason they treat it is because they actually are dispersed and penetrate the kidney for an infection, whereas some of the other ones do not. And they do get longer courses. So again, if I'm a little worried about someone, I may do a little bit of a longer course. Post-treatment follow-up, most people should feel better, usually within 24 to 72 hours, but 3 to 7 days. If you're not better at 7 days, okay. If someone gets better, we do not do tests of cures. So many patients want tests of cures. Have I done them? Yes. Some people are very adamant. If you have a test of cure that's positive and you have no symptoms, I ain't treating you. So I don't do it because it's asymptomatic bacteriuria. We don't treat that because every good national society says, we leave it there. The risk of that turning into sepsis is really low. Now, do we all have the patient who's come in and says, I was asymptomatic and then I almost died and I was hospitalized in the ICU? I was like, that's very sad, but I also am not going to just throw antibiotics at you for this E. coli that you never cleared. Because some little old ladies are just always going to have E. coli in their bladder. And no matter what we do, we can't get it to go away. So that's why we only treat asymptomatic. Now, if somebody is really symptomatic and they really think it's a UTI and their last culture was negative and they're like, I don't believe you, bring it back in, do a straight cast same day specimen. I don't say that to be mean, but that's because sometimes people get false negatives and they just need it straight from the source. And then certainly if somebody had a positive culture, we get a lot of these symptoms come back. I am not a huge fan of, I've seen somebody got a 7-day course of antibiotics, they have still have symptoms, we send them in for another 7-day course. I'm okay with maybe extending the duration up to 7 days if the symptoms are still persistent, but I would not really do more than 7 days without telling them, come back, let's make sure no resistance is developed. But that's kind of just my practice. We're getting close. So UTI prevention, this is a lot of what we talk about as providers. Goal is to minimize the impact on their quality of life. That's really my biggest goal, but also avoid them ending up in the hospitalized with a kidney or infection or sepsis. Antibiotics, we use these. They have risks. Resistance is the biggest one. And we care about that as a medical community at large and with patients specifically because we don't want to run out of treatment options for them. GI side effects, and then there are some, like lung, liver, skin, all these different toxicities that can happen with long-term use. Macrobid can cause pulmonary toxicities. Bactrim can cause some rare skin kind of necrolysis side effects. Sometimes we'll do continuous antibiotics. Usually I'm doing those 3 to 6 months. I couldn't find the study for this, but I have found some study that said up to half of women don't have UTIs come back is bad when they're on those continuous antibiotics. That's not what the recent AUA guidelines say, so TBD on that. But these are not recommended beyond a year. I have a rare patients who are on it for more than a year. They fight me tooth and nail for it, but it's not a great long-term solution for this. So usually we'll do it for a few months, do a holiday, and then figure out a different management plan, kind of use that until other preventative methods kick in. Some people do prevention after sex. I love this one if they're triggered by sex. And then rarely I'll do patient-initiated antibiotics where I say, you get 3 scripts from me a year. Now that we know, I usually only use that in people where we know it's a UTI, it's predictable, it's not resistant. I say use them up. If you run out of them or you're not getting better with that antibiotic, you got to come in and give me a specimen. And then these are the different things we use for prophylaxis. I mostly use Macrobid 100 milligrams daily with trimethoprim, and then I'll use some of the other ones pending resistance. And some of this is if somebody comes in and they're a current UTI patient and they're on suppression, and you notice that their urine culture is resistant and you pick that up, please send it to me, because sometimes I will actually change the suppression they're on pending those cultures. And then other non-antibiotic prevention, my favorite is vaginal estrogen. It reduces the number of UTIs postmenopausal women get by half. It actually changes the microbiome so that the good flora fight off the bad bacteria causing the UTIs. Cranberry juice, or excuse me, cranberry tablets has some decent data saying that it's not as good as antibiotics, but it's pretty good. I used to tell people cranberry juice doesn't do anything, but recent studies say, hey, maybe actually it does. I think the pendulum swings every few years. But cranberry tablets, juice, whatever, you do need to have a certain amount of bioavailable. The proanthocyanidins is like the thing that actually prevents bacteria from binding to the bladder. The problem is there's no FDA regulation. So I do not have a single formulation of cranberry tablets that I can validate. All the ones in the studies are specially formulated. So I'm like, I don't know what's in this. It might help, it might not. I don't think there's any harm to it. Methenamine is like a bacteriostatic thing. It's not really an antibiotic. It turns into formaldehyde and ammonia in the bladder and it stops them from replicating. Historically, we were told you need to add vitamin C to acidify urine. Studies say that doesn't make a difference, so it's just the methenamine. This is not as beneficial as antibiotics, but is probably some benefit in recent studies. So a lot of times we'll transition patients to this once we stop antibiotics or use it as an alternative because it's thought to be a little safer. And then increased hydration really is only thought to be helpful if you're drinking less than 1.5 liters a day. D-mannose may help, may not. I say don't break the bank on it. It kind of depends on what study you see, but I have a lot of patients we'll do that for. This is our current protocol. In the interest of time, I know we're like pretty much at our limit. These are kind of the takeaways. I'm just gonna go ahead and see what questions, comments people have before we have to return. You know, I know with our protocol are we still doing Cipro for our third line, is that right?
I haven't looked at it.
Yeah, I think that's so. Does anybody like who's triaging these phone calls have any big concerns that you want? I'm happy to talk about this later, but any big concerns you want to make sure we address kind of with the current protocols?
I know Kelly and Bryce both, if the patient was over